providing the slate.
Right, esteemed members, good evening and welcome to today's webinar. If you can hear me, just let me know on the chat and just let us know which BSK branch you're joining us from. Thank you for the thumbs up. Also, just let us know which branch of PSK you're joining us from. Right, thank you, Dr. Jasprit, Dr. Paul from Nairobi, Dr. Shamila from North Rift, Karibuni. Thank you so much for joining. Lower Eastern, Mombasa, Dr. Arifa. Welcome. Thank you. Thank you so much for letting us know where you're joining us from. All right. Thank you all. Good evening once again, and welcome to today's webinar. And today's webinar is on the value of HPV vaccination on cervical cancer elimination. And this session is being sponsored by MSD. This is a journey we started some few months back, and we're glad to be having the first session today. And we're looking forward to having more partnerships with MSD on training or with regards to HPV and vaccination. So I warmly welcome you to today's webinar. And this important conversation has come at a time when cervical cancer still remains as one of the leading health challenges among women in Kenya and globally. And as pharmacists, we play a crucial role in raising awareness, improving access, and supporting vaccination programs that can save lives. So for today, it's an opportunity to learn, share insights, and also strengthen the collective efforts towards elimination of cervical cancer through HPV vaccination. And before we start, I'd like to remind you to subscribe to the event on the PPB portal. You can use the keyword HPV or vaccination, and you should be able to find the event. So just take a minute of your time, go to the PPB portal and subscribe to the event. Remember, the earlier you subscribe, the earlier you're able to get the CPD points from a national CPD coordinator. And a few ground rules, you'll be muted during the entire course of this session. And if you have any questions, kindly use the Q&A tab. The speaker will be able to address the question at the end of the session. So this is an overview of how the program is. We'll be having a presentation by Prof. Menge. We'll be speaking on the value of HPV vaccination on cervical cancer elimination. Then thereafter, we'll have the Q&A and then some remarks from Thabiso, who's joining us from MSD South Africa. So as I introduce the speaker, we'll be having a poll, and I'd like to request you all to just participate in the poll that I'll be launching just now. If you can see the poll, maybe you can just send a thumbs up. and participate in the poll. All right, thank you. I see some of you already participating. So kindly just take a minute of your time and give us feedback. This will also help us with planning the future sessions and just gauging the understanding around HPV and vaccination. Okay, so I see over 100 of you have participated. For those who have not participated, kindly do so. We have only 6 questions and it will take less than a minute of your time. The first question is on your level of understanding around HPV and importance of its vaccination. The other question is the level of demand or inquiries that you see around HPV vaccination in your areas of practice. The other question is the gender that asks for HPV vaccination, mostly in your area of practice, and whether you provide HPV vaccination in the pharmacy. What support would enable you to expand into HPV vaccination in your area of practice? And finally, are you willing to vaccinate? So in the end, after this presentation, we'd also like to know if you'll be willing to vaccinate. So stay in and based on the presentation, we'd like to get to know your feedback as well. So I see we are almost half, 550. We have 250 of you who've participated. For those who've not participated, kindly do so that we can get started. For those who've joined us, we are doing a poll, and I'd like to kindly request you if you can participate in the poll and just give us your honest feedback. This will help us with the planning around the future activities that we'll be having with the MSD.
587, 586. 600. Numbers don't lie. Now.
Tabiso, I think you're muted. Okay. All right, I think that's why we'll stop the poll for now. And we'll be able to see the results. So on the level of understanding around HPV, we have 88% of you who've said you have a mid understanding. And with regards to the level of demand, I see medium and low have 42%, and the gender of the highest gender asking for HPV vaccination in your area of practice is 98% female. Then if you currently provide vaccination services in the pharmacy, I see 91% out of 329 who've participated. They don't provide, only 9% do. And in terms of what support you need to expand into HPV vaccination, there's in-pharmacy training 40%, CMEs 37%, and patient and pharmacy education material 23%. And are you willing to vaccinate? I see 91% saying yes and 9% no. So we're going to now have a presentation by Prof. Menge, whom I'm going to read his bio as he shares the screen. So Prof. Menge is a consultant obstetrician and gynecologist and a gynecologic oncologist at the Department of Obstetrics and Gynecology at the Aga Khan University, Nairobi, Kenya. He's also he graduated from the University of Nairobi School of Medicine and later completed a Master's of Medicine in Obstetrics and Gynecology in 2005 from the same university. He completed a clinical fellowship in gynecology and oncology in 2014 and holds a Doctor of Medical Sciences PhD from the University of Antwerp in 2019. Before joining Aga Khan, he served as a chair of the Department of Reproductive Health between 2015 and 2020. He was instrumental in developing clinical fellowships in the department. He's the founding director of the largest cervical cancer screening program in Kenya, which is AMPATH Breast and Cervical Cancer Prevention, ABCCP. His research interest is in the interplay between HPV and HIV, cancer, cervical cancer prevention, early diagnosis, and treatment. He is a principal investigator in multiple NIH and non-NIH funded research projects, and he has published over 80 peer-reviewed journal articles and presented in local and international conferences as an invited keynote speaker. He's a member of the International Gynecology Cancer Society, IGCS, and also the IPVS, which is the International Papillomavirus Society, and also the American Society of Clinical Oncologists. He's also a fellow of East Central and Southern Africa College of Obstetrics and Gynecology, FCOG, and also the Kenya Medical Association, as well as the Kenya Obstetric Gynecology Society. So at this point, I'd like to welcome Prof. Omenge to give his presentation. So you can just assist me in giving reactions. Give a round of applause as Prof. Menge comes in. Prof. Menge, if you can hear me, you can just share your screen. I think.
Good evening. I'm not sure you're seeing my screen.
We're still seeing the Zoom, so maybe you can just navigate to the presentation.
You're seeing the presentation?
Yes.
Thank you very much, and welcome all to today's webinar, where we'll be discussing the HPV adult vaccination and exploring why it is important and how does it safeguard women against cervical cancer. You know, so already the person who introduced said cervical cancer is a very important cancer among women, but not just women. We have HPV causing cancers that affect both male and female. We only talk more about cervical cancer because of the menace that it causes and being the second most common cancer among women and the leading cause of cancer deaths among women. And for that reason, then we emphasize on cervical cancer. Tonight, we will be talking about vaccination of adult women, but by extension, boys can as well be vaccinated. I want to declare that I've spoken and consulted for MSD, and the content of the slide that I'll present is material that I can stand for and not necessarily belonging to MSD. So, as I started alluding, human papillomavirus is one of those very common viruses that infect human beings, and there are over 200 subtypes of human papillomavirus, but about over 40 types infect human beings through the sexual organs, through the sexual tract. And among all those that affect women, about 12 of them or so have been classified as high risk. So you'll hear the terminology high risk HPV. High risk HPV are those ones that have been known to cause cancer of one type or the other. And 12 of them or so cause cervical cancer. We do know that there are those that are referred to low risk, meaning they don't cause cancer, but then they cause growths around the anal and the anogenital area, the anogenital warts. And those are the type 6 and 11. human papillomavirus is that common that it is estimated that 80% of us will get infected with human papillomavirus in the course of our life. It is mostly asymptomatic, and nobody really says, oh, I have gotten an infection with HPV. It's very, very silent. And if one is not vaccinated, 4 out of 5 women, if you count 4 out of 5 women, will get an HPV infection in their lifetime. The good thing is that by and large, HPV infection is a transient infection. So people get it, they clear it through their immunity, they clear it from the body, and so it doesn't cause problems. We actually, however, get concerned about the infections that persist. So somebody gets infection and a few years down the line, they still have the infection. Those are the types that then transform the epithelium of the cervix over time to become pre-malignant, meaning before cancer, and then malignant. It takes a very long time from the time one gets infected and to the time one will be diagnosed with cancer. On average, takes about 15 to 20 years from the time one was exposed to the high-risk type, HPV, then maybe they did not clear it, then it transforms to high-grade precancerous lesion, and eventually cancer, 15 to 20 years. But 15 to 20 years is among those women with whose immunity is competent, they are immune competent. Those who are immune incompetent, for one reason or the other, either they have HIV infection or they're on immune suppressant therapies, for example, people who have organ transplants, then their progression from HPV infection to invasive cancer is much less, is probably half that duration. When you look at what do we have then to prevent HPV, how can we encounter it? So you have vaccination that has been around with us. Disappointingly, despite the fact that the first time HPV vaccine was administered in the US and Australia, the two countries that adopted it very fast in 2006, by 2019, 15-year-old girls who had ever been vaccinated globally was about 15%. And if you look at Kenya and in sub-Saharan Africa, the uptake of HPV vaccination among 15-year-olds up to 15-year-old is in sub-Saharan Africa is less than 40%. And in Kenya, from the data that we have from the National Immunization Program, only 25% of girls have ever had the first dose or took the first dose, got the first dose. And you see, it will take a very long time to vaccinate everybody if we don't put all our hands on the deck to up the vaccination thing. And it's worse for Kenya and sub-Saharan Africa, particularly post-COVID time, because around about the time of COVID, vaccine hesitancy went very high. People started having suspicion about vaccination, and HPV vaccination was one of those that were hit because in Kenya, we introduced the HPV vaccination around about 2019, and then we got COVID 2020, and that vaccination program hasn't really picked very well. There's evidence that infection with human papillomavirus occurs through the continuum of life of a lady. The data that I'm portraying is a Colombian data that shows that the majority of the women would get their HPV infection in the teens and early 20s. But actually, you see it goes on even those who are above 45. So there is no specific age that one is immune from getting HPV infection. Whereas it's highest when they start having sex around teens and early 20s, but it continues through the lifetime. We then have a very interesting scenario of acquisition and prevalence of HPV in women. And this is in many regions. We see a bimodal age distribution of adult female with the HPV acquisition. So the graph on the left shows Africa, and the right one is Americas. In Africa, for example, we see it bimodal in the sense that the highest preference up to 45 or over is in those who are below 25. It keeps going down, and we have a kind of a trough in their 30s. But again, you start seeing it rising in those 45 and older. There is an explanation why we have the bimodal. Even the Americas, as much as they don't have the peak in the second phase as peak as the Africa one, but this is globally a distribution that has been noted, and there are reasons that I can explain this. So the first peak is because, of course, when girls start having sex for the first time, they are in the college, they have they are experimenting sex, they're having multiple sexual partners, so they are exposed to HPV, but also their epithelium of the cervix hasn't matured, and the immunity hasn't matured, and therefore acquisition is higher in at that age group. And again, they have not learned a lot about protection, and so they do not know much of the protective activities that can help reduce acquisition of HPV. But again, then we see in the middle ages, women are more in reliable relationships. They are married. And therefore, when you do the screening, it's not as peaking. Then it starts peaking much later in life. Explains by a few reasons. For example, there are women who are going into perimenopausal age, and around that time their hormones starts misbehaving a bit, so they start getting easier to get infection. But again, at around that time, as the older they get, the immunity, the body immunity starts reducing, and therefore even the HPV that was lying dormant gets expressed as your immunity starts waning. And the other reason is also, we do know that around that time, marriages or relationships starts becoming shaky, and that's when you get divorces and separations, or you start getting people bereaved, and so they start getting new relationships again. So we start seeing peaking. But also, these are the people who also do wellness checks, and they do screenings. And so probably the peaking, the getting of and detecting of more of the HPV could also be related to the fact that these are stable people who are keen on their health and therefore go for screening. Modeling predicts that between when does one get HPV and when do they get cancer. There are modelings that have been done, and it shows that about 50% of women diagnosed with cervical cancer were predicted to have been infected with a causal HPV after age 23, 50%. But there is 25% who got it after 35 years of age. And so this emphasizes what I had already initially indicated, that infection of HPV by women is throughout life. It's a continuum. It's not a specific point. There might be a higher preference at a certain time and at another time, but it's a continuum. I had indicated that much of the HPV infections that women get is transient, and that they'll clear it by themselves. It takes about a year to 2 years from when one is infected to clear the HPV. But when you look at the kind of protection one gets by being exposed to HPV, it's just a modest reduction in subsequent infections that one gains from a natural infection. And for example, HPV 16 and 18, the natural immunity only reduces the risk of getting the next infection by 30 to 35%. So this is one of those infections that doesn't give us excellent natural immunity by just the virtue of being exposed. And the other thing is that once somebody has gotten cancer that is HPV related, for example, cervical cancer, they are at risk of getting another HPV related cancer. For example, if one has had cervical cancer, they are 8 times more likely to develop vulvovaginal cancer. Those who have had vulvovaginal cancer are 14 times more likely to develop anal cancer. What happens is that the mechanism of changes, the dysplastic changes that leads to cancer in one area, happens in the neighborhood, so in the epithelium that is similar. For example, the cervix epithelium that it replicates and therefore undergoes dysplasia and eventually cancer is the same epithelium that we have around the vulva and the vagina, and therefore we have what we call field effect. So once you've had changes in the cervix, you have the same changes probably occurring around the vulva, and therefore you are at higher risk if you have gotten cancer that you might end up with another cancer that is HPV related. We have enough evidence now, scientific evidence, and a clinical rationale to propose that adult women or adults should be vaccinated. I've already alluded from the presentation that I've made that we have very poor natural immunity, for example. And therefore, we should be able to boost adults with immunity acquired from vaccines. But in a nutshell, in this slide, I present evidence or compelling reasons why we should vaccinate women or adults. And one of them is that adults remain at risk of acquiring HPV regardless of their relationship status. And therefore, the magnitude of that risk is being debated. What this means is I've met women who come to our clinic back after you've done screening. The recommendation currently is using a highly sensitive and method of screening, and the one we have is HPV DNA testing. You remember probably that we were using visual inspection with acetic acid or cytology, but the recommendation by WHO is now that we use, if possible, visible and available HPV testing. So you screen people and they test positive for high-risk HPV, and then they come back, the woman comes back dragging the partner and saying, but I've been monogamous for 15 years, or we've been in this marriage for 20 years. Where did I get the HPV from? And looks at the partner, and the partner is like, yeah, I've also been monogamous, so where has it come from? So adults still remain at risk of getting HPV because of the dynamics of change of relationships or the presumed monogamous relationship. And I had explained that even natural immunity, rather your age as you age, is possible that your immunity wanes, and therefore what you had acquired before you met the so-called monogamous partner may show up later on because of the immunity waning. The second is that most adults are not vaccinated, and the past infection is not protecting from the infection with another genotype. So if one had gotten a HPV 16, they can get HPV 31, they can get HPV 45 if they change a partner or if they come in contact with somebody who's infected with that type. HPV vaccination have shown to provide protection in adults. This includes protection from disease due to reinfection and infection with same or new genotype. In the subsequent slide, I'll be able to demonstrate that this evidence is there and there's data to back up that. HPV vaccination are licensed for adults in most countries, and several medical associations have recommended vaccination. And I belong to Kenya Obstetric Gynecological Society, and in our society, we recommend that women be vaccinated, or rather adults be vaccinated with HPV. So in this slide, I attempt to demonstrate that even if somebody is infected, meaning you do HPV PCR and it turns positive, they still benefit from vaccination. The vaccination you give them will prevent new infections and disease by the other genotypes. And so they qualify to get. If somebody had been exposed before to HPV, certain genotype, and currently they are uninfected as evidenced by being seropositive, but HPV PCR is negative. If you vaccinated them, it prevents reinfection and disease by same genotype that they had been exposed before. So this vaccination is useful for what they had been exposed before and any other vaccine covered genotype. And so it emphasizes that you do not need necessarily to test people before you give them a vaccine. So there's no requirement that, for example, if a woman comes and asks for give me a vaccination, a vaccine, HPV vaccine in your pharmacy, and you have it, there's no requirement that you send them for testing for HPV, then you give them. No, you can go ahead and give them, because one, even if they have current infection, they'll be protected from other genotypes. If they have been exposed before, it will protect against reinfection from the same genotype or the other genotypes covered in the vaccine. I'm sure you're aware that we have various types of HPV vaccines available. We have the bivalent, the quadrivalent, and monovalent. The bivalent basically covers 16 and 18. HPV 16 and 18 are the commonest HPV types that cause cervical cancer. It is estimated that over 70% of cervical cancer is associated with HPV 16 and 18. It depends on regions. A study that we did here in Kenya on tissue blocks from HPV, from cervical cancers in Western Kenya, did find HPV 16 and 18 causing 92% of the cervical cancers that we had in Western Kenya. And yet, the same study, we compared Western Kenya, we compared Kenya, the US, and Botswana. Whereas the US and Kenya, the HPV 16 and 18 were the dominant and over 90%. In Botswana, it was about 64%. So regions have variations, and therefore it is important that people get to know what is the most common and whether it will protect. But in Kenya here, even the bivalent alone would be very useful. We have the quadrivalent. It adds the other two low risk, 6 and 11, that cause anogenital warts. And we have the non-avalent that then adds the other another 5 more high-risk HPV types. But even if you just gave the quadrivalent, for example, based on the data that we have for Kenya, you will have covered close to 90% of HPV causing cervical cancer, and you will have covered the anogenital warts. The slide that I've projected tends to explain the median age at which CIN2+. So CIN stands for cervical intraepithelial neoplasia, and those are the changes that occur on the cervix from the time of infection of the HPV to when one gets cancer. The high risk, the high grade lesions or pre-cancer lesions are either CIN2 or CIN3. CIN1 is not pre-malignant, and because majority of them do regress. But by the time you pick CIN2 or 3, you are tethering close to going into cancer. And so this model predicted that a majority of the women in the US had CIN2, that's pre-malignant, by the age of 28. But remember, it takes very many years, even from when you've gotten CIN to when you'll get invasive cancer. Majority of cancers, we do see women in their 40s and early 50s, but they had that pre-malignant lesion probably around their age 28. And that's important. Then screening becomes very important to pick the pre-malignant and treat so that the people don't go ahead to get cancer. We have accumulated over 15 years data on the quadrivalent vaccine and whether it protects the various changes that can occur if one is infected with HPV. The 15-year-olds to 26-year-olds, we have over 4 years for 14 years of experience looking at the long-term effect of HPV-related CIN2. Remember, CIN2 and above are the pre-malignant, and if you can prevent, a vaccine can prevent occurrence of the pre-malignant, then you have prevented cancer, hopefully. And we the same data on males 16 to 26, females 9 to 15, because this was the original group that was being vaccinated, and females 24 to 45. The 24 to 45, this is a new addition. Remember, vaccines initially were for preteen people, but adults now have been added, and there is accumulation of information that relates to the outcomes if you vaccinate them. And the results are as follows. So it's effective. The quadrivalent vaccine has been effective in reducing cases of high-grade cervical lesions, anal epithelial dysplasia as well, and vulvar and vaginal cancers. 100% effective in reduction of that in an accumulative 14 years experience of that. And males as well in reduction of external genital warts or high-grade anal precancers. Remember, as much as we've been talking about cervical cancer, there are other HPV-related cancers. In the women, we talk about cervical cancer, we talk about vulvar cancer and vaginal cancer, and even anal cancers, but head and neck cancers as well. In the male, we talk of anal cancers, particularly in men who have sex with men, and then head and neck cancers. And therefore, from the slide I've projected there, this quadrivalent has been 100% effective in reducing most of those pre-malignant conditions that will lead to those cancers. That is a publication in the Lancet that was published about the work that has been done in Rwanda. So in Rwanda, it's one of those success stories actually on vaccination. They did serial preference studies to look at the preference of human papilloma infection in Rwanda from before when they started the vaccination and up to recent. And before they started, the HPV that prevalence in the community for those HPV in the vaccine, they were using the quadrivalent. The prevalence of HPV that is covered by that vaccine, it covers 16, 18, 6, and 11, was 12% in 2013, 2014. And as they continued vaccinating girls, and their vaccination is school-based, and as they continued doing that and doing catch-up, they noticed by 2019, 2020, the prevalence had gone down to 5%. Meaning that the circulating virus in the population had been reduced by just implementing the school vaccination. So, because once you vaccinate a bigger number of people, then you have fewer people who are circulating the virus in the population, and you benefit from even what we call herd immunity. WHO did make a call for action for cervical cancer elimination. And the director, Dr. Tedros, said 1 woman dies of cervical cancer every 2 minutes. Each one is a tragedy, and we can prevent it. And for the first time ever, the world has committed to eliminate a cancer. Never had that happened, that a world unites to eliminate a cancer. And so cervical cancer is one of those, it's one cancer, is that cancer that WHO has read a clarion call to try and eliminate because it's feasible. And the reason why it's thought that it's feasible, all the modeling have shown that we can actually eliminate cervical cancer. It's because we know the cause, human papillomavirus. We know how it is spread. We know how we can prevent it, and we have the preventive mechanism. We have primary prevention, we have secondary prevention abilities, and therefore, if we put our collective effort in this, we will be able to overcome it. And this evening, we are talking about vaccination, which is the primary prevention strategy when it comes to HPV and cervical cancer. Leading global medical societies are advocating for adult vaccination. And you know, it makes sense and makes actually a lot of sense. Remember, most of vaccination, HPV vaccination, is targeted to premenstrual girls, young girls. Again, from the slides that I had shown you people, is that a majority of the 15-year-old by age 15, very many will not have been vaccinated. So they become adults. We can do what we call catch-up now that it has been approved, the vaccine has been approved to age 45, we can then do a catch-up and give those who did not get it when they were in that age group that free vaccination was being offered. And in so doing, we'll be moving towards eliminating cervical cancer. We have opportunities to do so. And the slide that I've projected does show the touch points within a health facility. And so within a health facility, we want to have a touch points that women come to, where we interact with them. And many adult women, we interact with them at maternity and postpartum time. So they attend our antenatal clinics. That's an opportunity to talk to them, counsel them about HPV, tell them what cervical cancer is, and the ammunition that we have that is called vaccination. And then after they deliver, offer the vaccination, either before they go home or when they arrive when they come for postpartum clinic. We again meet them at family planning. They come back, they want either those who have delivered, or even if they've not delivered, they desire to start a family planning method. Then that's another opportunity to engage and offer education and vaccinate those who agree to it. OBGYN clinic for any other reason. Somebody has a discharge, somebody has a menstrual issues, and they are coming for clinic. That's another touch point. We meet women and we talk to them about it. And this is something that is already happening, by the way, within Kenya, within Nairobi, and many other countries, that now healthcare providers are taking the opportunity at the touch points where they meet the eligible women to talk about vaccination and offer them vaccination. Wellness visits, people come for to just have a wellness check, and then we offer that opportunity to educate them, and if they accept, they partake of it. There is evidence that cervical cancer counseling and vaccination opportunities exist in those touch points for women. And when you give them the knowledge about it, it increases uptake and therefore helps us to fight this scourge of cervical cancer. I won't bore you with why we offer for postpartum women, but there are reasons, and that reasons I talk a lot when I'm talking about to clinicians, particularly OBGYNs and midwives, why it is so important to give the postpartum. But opportunity landscape for the postpartum women, the rationale really is that this is the best time to educate them of the risk of HPV and family health considerations. A lot of them have healthcare access at this time, childbirth and things like that. They prioritize that a lot. And the timing for immunization is apt because the postpartum women, they bring their children for vaccination. And so if they learn that there's a vaccine that can prevent them from getting cancer, then they also prioritize their lives as much as they're prioritizing their babies' lives by giving them immunization. HPV vaccination is offered, if offered, can prevent HPV-related cancers, and that's a big thing. And the touch points are the ones that I've already said. But I think for pharmacists, you have a big opportunity because you see a huge traffic of people pass through you. Some come to inquire about certain services, and you get an opportunity to then engage somebody to let them know that other than what they've come to look for, they should also think about HPV and vaccination, since it does protect them, and there's evidence that once vaccinated, their immunity becomes better. They clear infections or reinfections, and therefore they're protected against cervical cancer. And not so just cervical cancer, we think they are protected about the other HPV-causing cancers. There are studies that have been shown to demonstrate that if you do proper counseling, the uptake for HPV vaccination does increase. And an Indian study that was done, the graph there does show the green one is before counseling and the blue one is after counseling. Awareness of cervical cancer tremendously increased after counseling, and as well as awareness of the HPV vaccine. So information is information. is key. The barriers to HPV vaccination among adults is really insufficient knowledge and lack of provider recommendation. I tried to talking to my other providers, other healthcare providers about HPV vaccination among adults. Believe me, that even amongst us as healthcare providers, we lack this information. When you talk to them, they know, but the vaccine is for girls. They don't even realize that even boys can get it. But again, it's for girls, not adults. And so we need to share this information and make people aware about it. And therefore, they will be able to provide. A healthcare provider cannot propose to a client something that they don't know that actually happens. Like they cannot say, you can also have be vaccinated against HPV if they don't know that it's available and it can be done to adults. And so in a US study, based study, data did show that women 18 to 45 years old were more than 11 times more likely to get vaccinated if they received a provider recommendation compared to adults who did not receive a recommendation. Like if we left it to nature, we left it, don't talk about it. And then we have another group whom we talk to. Those that we talk to and recommend were 11 times more likely to take up that vaccine as compared to those whom nothing was said about. And somebody quoted and said, if people were told about the cancer, they'd want to get vaccinated. The relationship between that human papillomavirus and the cancer and that vaccination protects them, they will partake of that. I want to come to questions or issues that go around the minds of people when they hear about vaccination against human papillomavirus. And one of the very common is, can HPV vaccine cause infertility? You know, the hesitancy about vaccines. You know, you've heard a lot about some famous philanthropist. Whenever he tries to help, they say, oh, you remember the recent one early this year where farmers said, oh, you cannot vaccinate our cows. Same thing. We face a backlash. People think that we are proposing HPV vaccination so that people can become less fertile. There's no evidence to that. And therefore you can offer it without worry. The other one is what I had already talked about. Is screening required before receiving HPV vaccine? No, absolutely not. You can offer it without screening. However, even after you've vaccinated that woman, she will need lifelong screening. I mean, until the age, depending on the guidelines in Kenya, is until age 65. They will still need to be screened against HPV, against cervical cancer. Remember, they had been exposed before, and therefore, even if we vaccinated them, they might just get a cervical dysplasia cancer from another subtype, HPV, that probably is not covered in the vaccine. We are not saying that the vaccines that we have is 100% covers all the high-risk HPVs. Is the HPV vaccine safe? Yeah, we have more than 15 years of safety data that indicates that it is safe to be given. Is the HPV vaccine safe to be used in breastfeeding women? Absolutely safe. And that's why, for example, one of the touch points we've said is antenatal and postnatal clinics. So we vaccinate them and they still go ahead and continue breastfeeding. Why should we vaccinate adult women in Kenya? This is my last slide as a recap. I had said cervical cancer is the second most common cancer and the leading cause of cancer deaths among women 15 to 44, age 15 to 44. Remember, death of a woman who is in her 40s, that's when her career is at peak, that's when children are going to school, and so losing a mother like that, there's evidence that a child who loses a mother never never reaches full potential that they would have in life. And actually that even means even their full growth potential, physical potential, mind and body and everything. And so losing a mother is serious. We should vaccinate. The HPV National Immunization Program that commenced in 2019 for girls 9 to 15, first dose coverage was just 29%. We have work cut out for us. We must do catch up with the women that are a little older than the ones that are covered in the free vaccine, national vaccine program. Most adult women in Kenya remain unprotected against the HPV-related diseases, including cervical cancer. So integrating adult vaccination into existing touchpoints is a convenient way to then vaccinate these women. And there are modeling that have shown that 50% of cervical cancer cases are linked to high-risk infections that were acquired after age 23, while 25% after age 35. So these women are still at risk. So vaccinating women until 45, you'll have covered, that is 50 plus 25, 75% of those cancers, rather the cancers that those women who are within that age group will have acquired HPV. Approximately 70% of newly detected high-risk HPV occurred in women in monogamous relationships. And therefore, you can imagine 70% of newly detected HPV, high-risk HPV, occurred in women in monogamous relationship. This is something that we need to discuss and face. So being in a monogamous relationship does not protect you from acquiring new infections. Remember, we said there are many reasons why in monogamous relationship you might see a peak in infection. Other than being really not monogamous, but we say that you may have acquired an infection from a previous relationship, then for one reason or the other, your immunity goes down, or due to stress, it could be hormonal or anything, then reactivation of a previous infection, and then it shows up as a new thing, and therefore we need to vaccinate. Natural immunity from HPV infection may not provide protection against subsequent infections, and therefore you need vaccination even if you've been exposed before. We need to catch up. We need to reach women where they are and provide them with an opportunity to be protected from HPV. And you as pharmacists, you as people working in the pharmacy industry, are well positioned to reach these women, and your touch point is that chemist, is that area, is that facility where you work. Thank you very much.
All right, thank you so much. Thank you so much, Prof. Menge, for that insightful presentation, and also just enlightening us on the critical role of HPV vaccination in the elimination of cervical cancer, and also just shedding light on how we as pharmacists can contribute to prevention and creating awareness on HPV. So I think we'll just get into the questions right away. And I'd like to encourage anyone who has a question, kindly put it on the Q&A tab so that we can be able to track it easily. And then please stay in, because we'll be having a couple of announcements in the end, and also just some few remarks from the MSD team. So we'll start with the first question, and I think for some of them, you've probably addressed them. And the first one is concerning the causative agent for HPV. Is it a predisposition factor for cervical cancer? And if it is the cause, what's the mechanism and pathophysiology in the host cell? I don't know if you've gotten that clearly. So if you can kindly explain if HPV is a causative agent or a predisposition factor for cervical cancer.
So HPV, we now know that 99% of cervical cancer are caused by HPV, direct effect. So what happens is when somebody gets, when one has sex with somebody who has, so a female has had sex with another person who has HPV, and ejaculation occurs, and those body fluids get into the vagina, they go to the cervix, and through micro abrasions on the cervix, the HPV then gets into the epithelium of the cervix, and the epithelium has multiple layers. Remember the epithelium of the cervix, the parabasal cells are near what we call the basement membrane. That's where regeneration of new cells occur. The HPV gets deep into the parabasal cells that regenerate and gets incorporated into the genome of the cervical cells, and therefore replicates and makes many more HPV. It replicates within the cell of the cervix. And then as the cervical cells, epithelium, as the cells grow and come up and then they are exfoliated. Remember, cells get exfoliated, and that's how we take pap smear, by swapping the cervix. The cells that gets exfoliated then release the virons, the HPV virons, ready to infect the next person. We have known that the changes that occur, the HPV suppresses certain mechanisms within the cell. You know, there's regulation of cell growth, and there are proteins that are specific in that cell growth mechanism that protects so that you don't overgrow cells. The HPV E7, there's something called oncogene 7, suppresses a P16, which is part of the cell, and causes the cells to multiply many times, and that's what leads to dysplasia and eventually cancer. It's a long mechanism that we can discuss, but basically that's what it means. So we now know that the HPV is a causing agent. Without HPV, we don't have cervical cancer.
All right, thank you so much. The next question is with regards to if the national program in Kenya has been able to expand to include boys and adult women. And maybe as you address that, you could also mention something about how many times can one do cervical cancer screening in a year?
So the vaccination by the national immunization program targets age 9 to 14 girls, not boys. The reason is really finances and resources. You know, you want to put public resources in the most impactful or where it will have the most impact. So whereas we say that the men also do get cancer from HPV, the most suffering is women and cervical cancer. And so that's why, as a public health perspective, they thought, let us put the resources in vaccinating girls. Other countries actually vaccinate both boys and girls. But in Kenya, no, the vaccine is targeting girls. It does not even target adult women. So the adult women have to buy the vaccine or find an access program that gives it, but not the government. What was the other question?
The other question is on the frequency or how many times one can do.
So remember, I quickly, you remember the graph, there was a slide that showed from acquisition to when you get cancer. Takes 15 to 20 years from acquisition of HPV to getting cancer. That's in immunocompetent person, not HIV infected or other immunosuppressive. So it takes very long, and therefore, even from changes from dysplasia and then into invasive cancer takes long. And that is the basis on which we were doing pap smears every 3 years, for example. So the recommendation now is that you do, if you're using pap smears, if you have had 2 normal, then you spread it to every 3 years. Now that we moved to HPV DNA testing, it gives us even a broader, once you have a negative HPV, you do it after 5 years. If you are HIV negative, you are not immunosuppressed. If you are immunosuppressed, then you will do it more frequent. For HPV, we do it every 3 years screening. So screening is not done yearly. It's multiple times in a year. No, it is done at least 3 times, every 3 years if it's a cytology, or 5 years if you're using HPV DNA testing. Thank you. I see there's a question about what is the success rate of cure of CIN after LEAP procedure. CIN3 after LEAP procedure, does the patient qualify for vaccination? So LEAP procedure is also called loop electrosurgical excision procedure. It's an excision procedure where we cut off the cervix part, the area that is called transformation zone. The transformation zone is the area where those cells become abnormal, and that's where cancer commonly starts from. And so when you cut it off, when somebody does cervical dysplasia, you kind of remove the cells that would have become cancer. And it is very effective. Effectiveness of loop electrosurgical excision procedure is in the ways of 95%, 94, 95%. And yes, this person who has a LEAP treatment does qualify for HPV vaccine. We do have trials of HPV vaccine as a treatment, but it hasn't been rolled into use as such. But we do know that HPV vaccination actually might reduce the lesion, but that's for another day. For this forum, we are saying yes, this person can get vaccinated.
All right, thank you for that. I think the other question is on concerning the dosing schedule. Maybe you can briefly say something about that.
So the dosing schedule is for the girls, they get 2 doses. First dose at 0, and the second dose after 6 months. You can actually get it even up to a year. But if you are older than 15 to 26, then you need 3 doses. So it's 2 doses for the girls, 3 doses for adults. There is, of course, studies that have shown that even a single dose for girls may be effective, but the follow-up of those girls is still ongoing to see whether the immunogenicity and the effectiveness of a single dose, how long will it be, or whether in future they will not need a booster. But the important thing really, and the encouraging thing is indeed if it remains that the immunity is lifelong, then you can imagine when we have been saying that they need 2 doses, then we are saying they need 1. So for 100 doses, which would have gone to 50 girls, will cover 100 girls. And for low and middle income countries, that will be tremendous work and saving that will cover more people.
All right, thank you for that. The other question is, are there any interactions between HPV and the family planning methods in the breastfeeding mom? And maybe, I don't know if you can also address on the issue about the myths about HPV vaccine, especially after the results of COVID-19, which brought about some side effects.
So yeah, so there's no interaction between the family planning methods and HPV vaccination. None so far. Remember, we've had the experience of more than 15 years vaccinating the girls, but close to now 10 or so years accumulated of women who are older than 16, meaning some of them got pregnant and some of them probably were breastfeeding. So there are no interactions so far. But to address the myths about vaccination, we do know that COVID-19 was a special moment. The vaccine did give people did get complications. So whether the complications came from the vaccination itself or the complication of the disease, it's neither here nor there. And so there are people who strongly believe that the vaccination affected people in a negative way and therefore it should never have occurred. I don't think HPV vaccine falls in the same category of being doubted. I do know that for religious reasons, for example, there are people who would not accept HPV vaccination just because the HPV is a sexually acquired infection, and you see when we give it to young girls, they say we are preparing them to be promiscuous. There are studies that have shown that giving somebody a vaccination to protect them from that cancer does not make them more promiscuous than their counterparts who never got it. And if you have seen the kind of cruelty that comes with cervical cancer, I keep giving this story that as a gynecologist, if you blindfolded me and took me to one of the public hospitals like Kenyatta National Hospital or Moi Teaching and Referral Hospital where I worked for many years, you blindfold me and take me to the ward, the gynecology ward, and to the cubicle where cervical cancer patients are, I'll tell you I've arrived to where cervical cancer patients are. It has a characteristic smell. Those women are dejected. They are ostracized. They don't attend social functions. You cannot deny a girl a vaccine because then she dies that way just because you think you are religious or moral standards do not allow you. So yeah, there are myths, but I think we can rise above the myths as healthcare providers and see the bigger picture of the benefits. Thank you.
Right, thank you for that. There's a case here of a girl who was vaccinated at 10 years. She was scheduled for the second jab after 6 months, but the dose became unavailable in the health facilities around where she lives. Does she still need another vaccination? And she's now 12 years.
Oh, that one, I don't know who will help me from. Is there anybody from MSD who can help me on that? But remember,
Yes.
we say that there are evidence that even one jab is as good. But let's hear what MSD says.
Perfect. So I think that's a good answer, Prof. Omenge. So it is advisable that they do still need one more shot of the vaccine, as it offers optimum coverage against HPV-related cancers, right? As we've seen that if you do not get optimal coverage or optimal shots, then there is still some risk of acquiring HPV-related cancer in the future.
All right. Thank you. Thanks for that feedback, Tabiso. And just looking at the other question, I think the other question that we have that I see being repeated a couple of times is concerning the cost implications in a private setting. And also, I see some members were asking if it's currently being provided in the public facilities, and are adults able to get the vaccination free of charge? So maybe Prof. Omenge, you could maybe give some feedback based on your experience.
So I don't think there is any public facility currently offering adult vaccination, but I mean, part of the effort that we are making and talking to groups like this is to first sensitize people that actually adults can be vaccinated to start with. But secondly, working with people who providers or people who supply the vaccine to make it available for women, adult women to get, but it is at a cost. So whereas the national immunization program gives it free of charge for girls within the age group that is targeted, anybody outside that age group has to absorb the cost, either by your insurance if you are covered, and if that insurance is covering vaccination, or out of pocket. So how much it costs and all that is beyond the scope of my talk, unless MSD wants to say something.
Yeah, so definitely thanks for that, Prof. Omenge. With regards to the cost of the HPV vaccine, so representing MSD, at the moment, I wanted to say this at the end, but I might as well jump in. Currently, we are happy to say that we have managed to reduce the price, particularly around Gardasil 4. So it is at $60 per dose, which is 30% less than what you used to buy it for or procure it for, right? So the $60 is equivalent to 7,800 Kenyan shillings. Now, so it is readily available at the moment, and it is available from Surgifarm. So if you want to order or procure Gardasil 4, you will definitely get it at Surgifarm at $60 per dose, and that's equivalent to 7,800 Kenyan shillings. So, Hezron, I also saw that there was a question around the availability of the nanovalent. Now, MSD is working around the clock to heavily invest in Kenya, whereby we will be launching Gardasil 9 in 2026, quarter two. So I think once the launch date has been finalized, communication will definitely be sent out to each and every one of you, and an invitation will definitely be coming your way to attend the launch of Gardasil 9. However, at the moment, Gardasil 4 is available at $60, which is equivalent to 7,800, and that is 30% less than what you used to buy it for. So you can definitely get it at Surgifarm. Thank you, Ezra.
And as
Right,
I
thank you.
indicated earlier, based on the data that we have from Kenya, Gardasil 4 is as good. If that's all we had, even nanovalent Gardasil 9 We will need it, but I think if I was to put my dollars, I would put it in the Gardasil 4, because then we already cover over 90% of what causes our cervical cancer. Thank you. Oops, I hope I haven't spoiled it for you, MSD. I'm just saying, just science.
All right, thank you, Prof. and Biso. I think the other question is, I think this you had already responded to. Is the vaccine beneficial if someone is already exposed? You said it's still beneficial to prevent recurrence. And then the other one that I see is, can one get vaccinated if they're already sexually active? I think maybe you can address that as you speak on some long-term side effects of HPV vaccine, if there's any data that is supporting.
The question is, if one is sexually active, they should be vaccinated?
Yes.
Well, that's where, yeah, the adults that we actually targeting are more or less sexually active, we think so. And also, yes, you can be vaccinated. And remember, we said you do not need to be screened for HPV types that you have to get vaccinated. And so, in terms of safety data that we have, the only the effect that is commonly reported is injection site pain, and we know, I mean, any injection can give you pain, but that's the commonest. And young girls, a few young girls have been reported to have syncope, that's fainting. And we think it is not because of the drug injection, but the fear of the injection and the pain that comes with it. None that has been long-term effects so far reported on terms of effects of HPV vaccine per se. Thank you.
All right, thank you for that. I think we should be closing in on the questions now. There's one who's asking if we could maybe shed some light on respiratory papillomas. I don't know if that is part of something you can discuss on.
Yes, so just the same way HPV 6 and 11 causes anogenital warts, papillomas, respiratory papillomas, are warts in the respiratory tract that are caused by HPV. We do get them, especially in children born to mothers who have a genital HPV, and therefore they end up with papillomatosis, and as well as people who have other modes of sex. But those ones get head and neck cancers. But we have a lot of debilitating effects of those papillomas in children. And you find children who've got multiple surgeries to remove their papillomas, and it is very devastating. Thank you.
All right, thank you so much. I think we'll take 2 more questions, but meanwhile, members, we've just shared a poll, and I'd like to request you to just give some feedback as Prof is just going to tackle these last 2 questions that we'll be having. So one is, can immunocompromised women get HPV vaccine? And I think the other one is with regards to if there are any national regulatory authority agencies that have approved the use of adult age groups HPV vaccine above 25 years, and if there are any, yeah.
So yes, immunocompromised people can get HPV vaccination. In fact, they're the ones who may need it more. Remember, I said that studies have shown that immunocompromised women have cervical dysplasia progressing faster from acquisition to cervical high-grade lesions to invasive cancer in a shorter duration compared to immune-competent people. That's number one. Studies that we've done also does show that the women who are immunocompromised, HIV infected, have multiple infection at the same time of high-risk types. So you will find the same woman with HPV 16 31 and like, so they have multiple infections, multiple HPV genotypes as compared to the HIV uninfected. And therefore this group actually, yes, if they meet the criteria, the age bracket, they will benefit enormously from vaccination.
All right. Thank you so much. I don't know if we should take more questions because I see they're still coming in. Do you have some time, Prof?
Yeah, I do, unless the people want to go have dinner.
Okay, because I know we have some announcements and I would also like to just get a parting shot from you, but allow me to just take one more, which is will MSD be taking Gardasil 4 available in KEMSA and meds to increase uptake in the public health facilities? I don't know, Tabiso, would you be having a response for that, or Prof. Omenge?
Maybe Tabis.
Yeah, definitely. I'll go for it, Hezron. So, taking it as far as KEMSA, so I think that is also on the cards. We are still having talks internally around that, and once those talks are finalized, then it will be communicated. But the plans are there.
All right. Thank you. Thank you so much. So I think esteemed
There's
members,
one to you. There's one to
yes.
you. How can we as pharmacy professionals and as PSK help to raise awareness about HPV and cervical cancer? I think that goes to you.
Okay. I think this is a conversation that we've already started with MSD, and we are planning on having, and that's why we're even having this tests the poll that we are running just to gather information and see which ways in which we'll be able to come through. So I'd say be on the lookout. We'll be having more CMEs coming up and also maybe some trainings just based on also some of the feedback that you give. So kindly ensure that you just share the feedback on the poll. I see 181 of you have given your feedback, but continue giving your feedback so that at least it will also guide us in preparations for the upcoming session with the MSD.
Just to add on to that, Hezron, that's a brilliant answer. One other thing that is also very important is HCP recommendation, right? So it's quite critical that from a pharmacy point of view, you are not only seen as individuals that dispense pills on a daily basis, but you are perceived as individuals that add value to the patient's lives. So I think a critical point that needs to be addressed and driven on a daily basis is active recommendation by the pharmacist to the patients, just to initiate that conversation with the patient that walks in there, whether they know about HPV and if they'll be comfortable to vaccinate, etc., just to give that basic education. So I think from an MSD point of view, what we will be doing is that we can happily support with the educational material to the pharmacies so that you can have those active discussions with your patients. Thank you.
Right. Thank you so much, Daviso, for that. And yes, for those who are asking about the poll, should be popping up on your screen. Just check if you have a poll section and you'll be able to get it. So I think at this point, I'd like to just welcome Prof. Omenge to give a parting shot, and then Thabiso, you can also say something before we get into the announcements.
My parting shot is that cervical cancer can be eliminated in our lifetime. We all have a role to play in ensuring that we support that. Vaccination is one, and therefore you guys as pharmacists have a role to play. The other people, other professionals who are healthcare providers who are in the screening space and treatment space will do their part. And together we can be able to eliminate cervical cancer. I'm a father to girls and have had them vaccinated. Thank you.
Right. Thank you. Thank you so much, Prof. Menge. It was an honor having you and also just sharing those insights. And we look forward to engaging you more in creating more advocacy around this. Thabiso, maybe you can come in.
Great stuff. Thank you so much, Hezron. So I'll just pull in a little bit of statistics. So HPV is very common, right? About 80% of all sexually active men and women will get infected at some point in their lifetime, right? And particularly in Kenya, roughly about in a year, there's 5,236 women that are diagnosed with cervical cancer. And of those women that are diagnosed with cervical cancer, there's roughly about 3,211 that will actually die, right? Women that are diagnosed with cervical cancer will actually die from the disease. So, what that means is that we need to be proactive with this particular condition, make sure that the individuals get vaccinated at quite a rapid rate as quickly as possible. Because if you think about it, and this is my parting shot. For a patient that has diabetes, for a patient that has hypertension, they are also asymptomatic. The symptoms are asymptomatic until an event happens to that patient. They can either experience a stroke or they can get one day later get amputated, right? Because their type 2 diabetes was not well controlled. So let's think of HPV in the same regard. It is asymptomatic. The patients don't feel sick, but one day they will get diagnosed with cervical cancer, and it has a detrimental effect onto the not onto the patient alone, but to the family as well. So I think very important. Let us treat it with as much importance as we would treat your type 2 diabetes or your hypertension. Thank you, Hezron.
All right, thank you so much, Daviso. And I've just shared the results for the post-test that we've just had. And the first question was whether you're willing to be vaccinated. We have 85% out of 244 people who participated who said they'd be willing to be vaccinated. And we also have the other question, which was on the common causes of vaccination retraction. 21% of you said the cost, while 79% said lack of knowledge. And I think that's part of the reason why we are also doing this webinar, so that you can also be enlightened on that. And then finally, are you comfortable to actively recommend the HPV vaccine to your patients? We have 98% of you saying yes, while 2% saying no. So thank you all for participating in that poll. I think that will greatly help us in planning the future activities. So as we close, I'd just like to once again thank Prof. Omenge, Tabiso, and Nicodemus, and the entire MSD team for the great support for this session. I think it was a learning moment for many of us, and we definitely we're looking forward to having more engagements just to be able to learn more. And members, I'd like to remind you that this week is the World Pharmacist Day, and on 25th, we'll be celebrating the World Pharmacist Day. And with us, we've planned a couple of activities. And the first one is the online campaign that we'll be running. So I'd like to encourage you to scan the QR code. I think this is some of the materials that we've also been sharing online. If you're able to share with us your image, your name, and your job title, so that we can also just share the message with our networks on LinkedIn, Facebook, and all other social media platforms. So kindly participate in our online campaign, share with us those details, and we'll be able to create this beautiful Twibbon so that you can just create awareness on your end. We have a couple of activities that will be happening, and this is specifically for the National and Nairobi branch. We have some media initiatives that will be happening in the next few days. We'll be having some media interviews. So be on the lookout. We'll be sharing links to that. We'll be having some of our members that will be talking in those shows. We have a blood drive happening at Mbagathi Level 5. Kindly make some time for those who are able to on 25th September. We have a CME at Heron that will be on weight loss management, a medical camp at St. Paul's Church, and finally, the InterVarsity Challenge with KEFSA. This happens annually, and we'll be having all the 9 universities meeting at the University of Nairobi. So if you're able to make some time and participate in these activities. The other activity is at Tana Athi branch, where they'll be having a session on prostate cancer that will be happening at the Kenyatta University Teaching and Referral and Research Hospital That will be happening in the morning hours. Then thereafter, they'll be having a dinner and pharmacy awards happening at Markland. So if you have some time, make sure that you pass through there. And this is not just all the events. We have some activities happening in all these other branches that we have across the country. So ensure that you find out more information about these events from your branch leaders so that you can celebrate the World Pharmacist Day. And that's the end of the session today. Once again, thank you so much for joining. Ensure you subscribe to the event on the PPB portal so that you get your CPD's points on time. And thank you so much for those who've been able to join. Thank you, Tabiso, MSD team, Nicodemus, and Profomenge. Once again, thank you so much from PSK. And we look forward to having you in the future sessions. Thank you.
Thank you. Have a great evening, everyone.